For a few years now, my lab's been focusing on trying to develop better models of glioblastoma. So glioblastoma is the most common brain tumour. It's very aggressive and the outlook is very poor. The average life expectancy is about 1 year. And our current treatment includes radiotherapy and a chemotherapy drug called temozolomide. But since that treatment was established about 13 years ago, we have made no further progress in the treatment of these patients. In particular, we've tried lots of new molecular targeted agents, and many of them were giving very promising results in the laboratory, but none of them have actually improved survival or improved outcomes for this patient group. So we figured that there must be something wrong in the way we're testing these new treatments if they look so promising in the lab, but they're not working in the patients. So what we've been doing is trying to develop better preclinical models of glioblastoma in which we can evaluate these potential new treatments. And there are a lot of potential treatments out there. It's just a matter of finding the ones that are going to work. So some of the work has been in mouse models of glioblastoma, but the main focus of my talk was on our cell culture models, which we decided very early on that part of the problem with the existing cell culture models is that people take cells from patients' tumours and then grow them as just two-dimensional layers on plastic surfaces. And when you do that, the whole character of those cells changes. The shape of them, the molecules they express on their surfaces, and also the way they interact with different molecules circulating in the medium. So we have set up a three-dimensional tissue culture model. It's based on a polystyrene scaffold, and we coat that with some of the extracellular matrix proteins that are present in the tumours. And then we seed the cells onto that three-dimensional system, and they can grow in a much more natural way. And if we look under the microscope, the cells are very rounded, and they're growing in contact with the scaffold, but also in contact with each other, which is what happens in the tumour. And what we also noticed was that they form very fine microtube connections with each other. And that's something that has recently been demonstrated in glioblastoma and has also seems to have quite important implications for their resistance to therapy. So as we look at this model, we are generally finding that they recapitulate a lot of the features of the actual tumour. So we think it makes a much better model for testing new treatments. So that was developing the model, and then we've gone on to start testing different drugs, but in particular testing drugs in combination with radiotherapy. So radiotherapy is the basis of all of the treatments of glioblastoma. Nearly all patients will get it, and we know that it is moderately or slightly effective. It does increase life expectancy, but patients often have a response to treatment. The tumour will shrink, but it inevitably grows back again. So we have to make that radiotherapy more effective. So using our 3D model, we can give radiotherapy, and then we can combine it with lots of different drugs, and we can do a screening approach to identify which are the most effective drugs, either on their own or in combination with radiotherapy. So in my talk I presented the sort of early results of that screen, where we found some really quite promising combinations which we'd like to take forward for further testing.